Good afternoon, esteemed guests, presenters, and colleagues. Welcome to Parallel Session 2.1 Dynamics of Population and Sexual and Reproductive Health. Our esteemed presenters will delve into key topics such as population aging and the influence of socio-economic factors on reproductive health. We encourage active participation and discussion as your insights and experiences are invaluable to enriching our understanding of these critical issues. So, welcome and let's get started. I'm pleased to introduce our session co-chairs for Parallel Session 2.1. First, we have Ms. Manuel Hurwitz, the Director of Development and Impact at the International Planned Parenthood Federation. I'm also excited to introduce Dr. E.L. Sunetra J. Pereira, the Professor, Chair of Demography Department at the University of Colombo in Sri Lanka. She currently serves as the President of the Population Association of Sri Lanka.
Very good afternoon to everyone and welcome to the session 2.1. As discussed with Ms. Manuel Havitz, so we are so fortunate to have her as one of co-chairs of this session.
So we will start without further ado with our first presenter, Maria Said. Maria Said is a member of the Society for Health Education, so that's the IPPF member association in the Maldives. And she served as vice chairperson from November 2023 to September 2024. Maria has over 32 years of experience as a medical laboratory technologist, and she formerly led the Thalassemia and Diagnostic Laboratory Services. So welcome, Maria. She will be talking to us about addressing reproductive health challenges posed by thalassemia in the Maldives, and she will specifically focus on examples from She Maldives program.
Thank you very much for the introduction. Assalamu alaikum and a very good afternoon to all of you. My topic is addressing reproductive health challenges imposed by thalassemia in the Maldives. Insights from She's outreach program. The presentation is co-authored by Dr. Naila Ibrahim Didi. The objectives of my presentation is to evaluate the impact of She's outreach program on addressing reproductive health challenges associated with thalassemia in the Maldives. Thalassemia is one of the huge public health concerns of the Maldives, and I think the beta thalassemia carrier percentage is the highest is in the Maldives from globally. The methodology was secondary data from She Thalassemia Prevention Initiatives. And we have had a national thalassemia prevention program since 1996, and we have the data we have used for this has been more than 100,000 people were tested. So it is 1/3 of the population. So from the screening and the DNA studies and genetic mapping, what I mean by genetic mapping is we have different variations of thalassemia carriers in different islands. The results of the study showed that high prevalence of beta thalassemia globin variants and prevalence of anemia in the carrier population of thalassemia and the hemoglobin variants. So the result is 1 in every 5 person is a carrier for beta thalassemia. So 1 in every 30 marriages are between 2 carriers, and 1 in 120 live births is a thalassemia major. We have found that 18.2% of the population carries a variant of a hemoglobinopathy. And specifically, if you look at only beta thalassemia, 16.3% of the population carries the gene. So from the results, we have understood the critical need for preconception genetic counseling, and premarital thalassemia screening we have made it mandatory before registration of marriages. And prenatal diagnosis was also introduced because of the thalassemia situation in the country. But it is very sad that still we cannot get it done in the country. We have to go abroad for any prenatal diagnosis. But we have now had affiliations with India, some of the hospitals in India, and we are able to send people just in time for them to do the test. And also, because of the thalassemia situation, the SHE program influenced establishment of many transfusion facilities and created high demand for thalassemia voluntary testing. Some of the children at the age of 14, 15, they are in relationships. And since they don't know their carrier status, they were very shocked that they can be carrying the gene and without knowing they have taken a boyfriend or a girlfriend. Nationwide screening program has made a lot of changes in the policies, like mandatory testing for thalassemia before marriage. Now we have a Thalassemia Act passed by the government. It is a very big challenge for screening to be conducted across the country. So we had to design our counseling package specific to the island need. The sexual and reproductive challenges that were faced by the thalassemia community made it mandatory to make the termination of pregnancy was legalized. Some of the choices that we give for couples who are carriers, some of them, they are in love and they cannot separate. So they decide to get married. But what are the options for these couples? The options that they can have is they can decide to not have children, or they can decide to have children and do a prenatal diagnosis and a termination of pregnancy in case of a thalassemia major. So we have long-term outcomes for couples, and intervention strategies has to be implemented more. Thalassemic population is becoming adults. For them to have a child, they have to be thinking of their sexual and reproductive needs from the time of their puberty. So all these has to be addressed. My topic is actually to help them have families, not contraceptives or other things. Thank you very much for listening, and this is my story.
Thank you very much, Dr. Said. A very, very good and concise presentation. We'll go to our next speaker, who is Dr. Asanka, who will present on the study of the results of an online study on knowledge regarding menopause. Dr. Asanka graduated in medicine from the University of Peradeniya in Sri Lanka and completed her medical internship there. She holds a diploma in family medicine and is an international member of the Royal College of General Practitioners. So, Dr. Asanka, please come and join us.
Good afternoon, everyone. And I'm here to present my research paper. It's about knowledge on menopause among women. It was an online study. According to the WHO, which is World Health Organization, menopause is defined as the permanent cessation of menstrual cycles for a duration of 12 consecutive months. Women's physical, emotional and mental health undergo dramatic changes throughout the perimenopausal time as well as the menopausal time. Perimenopause is a time where you have the transition. And also I would like to point out the first menopause-related National Institute for Health and Care Excellence guidelines was released in 2015. And that demonstrates the increasing recognition of its significance in healthcare. And also, in addition to that, menopause education was made mandatory in schools in 2019 as a component of relationships and sex education. There were some studies that I wanted to point it out. Research on younger women's education and understanding of menopause is quite limited. Objectives of my study is to assess the knowledge on menopause among women aged under 40 years living in Colombo. This is brief description of methodology used. A survey was created asking women under 40 about their knowledge of their opinions regarding the menopause. Questionnaire was a pre-tested questionnaire. Actually, the original study was conducted in China. A randomly selected sample of 225 women was selected. I have analyzed the level of knowledge regarding the menopause, educational experiences, learning about the menopause, and how knowledgeable do women feel about the menopause, how they had found information about the menopause, and the best places to teach people about the menopause, and the importance of teaching men about menopause. These are my results. As actually this shows the age distribution. 15% were less than under 20, 65% was in between 21 to 30, 20% was in between 31 to 40, 60 plus were married women, more than 30 plus was in a relationship, 120 plus were single ladies, 158 were with no children, 35 were with one child, 21 were with two children, around 11 had a mother of 3 children. The analysis of highest educational qualification showed that the 83 were with secondary school and 123 were undergraduates and 19 were postgraduate ladies. And the first graph shows the women asked how informed they feel about the menopause. And in the second graph shows women were asked how menopause was covered in their school lessons. In the third graph shows women were asked if they had been taught about menopause at school. And in the fourth graph, women were asked how they had gathered information on menopause. That shows that less than 20 was mostly got the knowledge about menopause from the newspapers, and from the analysis it shows that the social media has contributed a lot in 21 to 30 category, and when I considered the 31 to 40 ladies, it was mostly from friends. There were some parts of the questionnaire which was asking about the symptoms of menopause and the signs and symptoms of menopause. And according to the age, the analysis showed younger women who is under 20 are more likely to have learned about menopause in school, while it was far less likely to be covered in the education of older women, particularly those over 40. In conclusion, the majority of women under 40 know very little or nothing about the menopause. The analysis showed that everyone should be taught about menopause in schools, and this will help to lessen male ignorance. In schools, workplace, those are the main two places which I encounter to educate regarding menopause. Recommendations through my study. First is the effective menopause education in schools, local support groups to be introduced to help specifically for women going through menopause, where experiences can be shared and support can be found, introduction of lifestyle changes, diet and exercise, and also exploring the options such as acupuncture, yoga, or herbal remedies may help to undergo menopause. Educate the women explaining the benefits and risks of HRT to make informed decisions about managing symptoms. Introduction of mindfulness and relaxation exercises can help alleviate menopause symptoms, and also counseling therapy if menopause symptoms are impacting mental health.
Thank you very much, Dr. Asanka, for keeping to time and for a very, very interesting study. We will now go to our next panelist. I'm very pleased to welcome Dr. Sarah Wuswasi. Jangam. Dr. Jangan is a practicing gynecologist at FPA India, dedicated to addressing the sexual and reproductive health and rights of vulnerable and marginalized populations. She prioritizes client comfort, education about their health situations, and comprehensive treatment planning. And Dr. Jangam will present on sexual and reproductive health challenges, on population aging and the unique sexual and reproductive health needs of aging population, menopause, again, and the elderly. Welcome.
My topic says unique unmet needs of aging populations, menopause and elderly. Actually, as menopause is already something which is not discussed very frequently or very talked openly, same way are the unmet needs of aging populations. They are not talked openly or discussed openly with the population. Sexual and reproductive healthcare encompasses a broad range of services for a safe and satisfying sexual life as they enhance individuals' well-being. So this was the point which we could identify that well-being, we could, at the starting, we could cure their symptoms, but the well-being was not seen after even giving the symptomatic treatment. Meeting the unmet unique needs of SRHR can help us achieve complete health coverage of the aging population, address all that small problems where we could justify their total well-being. Sustainable Development Goal 3 suggests that states should ensure healthy lives and promote well-being for all at all ages. So we being in the present reproductive and generative for the growth, the elderly population should also be cared and not to be neglected. FPA India Pune branch, established in 1977, provides a range of SRH services. SRH needs of aging populations, including those undergoing menopause and the elderly, are often overlooked, especially after attaining desired family size. So my objective was to describe the unmet sexual reproductive health needs of aging populations between 45 to 60 years, including those undergoing menopause and the elderly. So the methodology we followed was this was the routine service statistics gathered at the FPA India Pune Static Clinic during January to December 2023. This was used for the study. FPI Static Clinic provides clinical and non-clinical SRS services to over 7,000 clients in a year. The first presenting symptoms were for STI-RTI services or gynecological, like white discharge, itching, and all. For that, they used to visit us first. The selection of the clients was based on their complaints, history, and duration, since how long they have been suffering. Here, dwelling into the personal history to know her unmet needs and her emotional status was also considered. These clients were educated about their conditions, discussed different options, and encouraged them to select their best suit for their personality. Before doing that, we took their consent for follow-ups and visits for checkups. The results we found out, the respondents of for this study in the age group of 45 to 60 years had visited with the complaints of severe low back pain, pain in the lower abdomen, dysuria, dyspareunia, vaginal dryness, vaginitis, severe weakness, feeling low many times, loss of appetite, loss of interest, etc. As a first step, menstrual, obstetric, and medical history of the client, family history, personal history, upbringing, social exposure, educational levels, her emotional status with her unmet needs, everything was considered. The study shows that 35% of women are affected among the sample group, and among that, 20% were suffering from the stress-generated symptoms. And 40% of menopausal women were found to be neglected regarding their sexual health and well-being. The frequency, we can say, is 1 in every 6 women is affected. All their medical issues were addressed and assessed. Their gynec complaints were treated. The use of personal lubricants opened new options for the pleasure. When we said sometimes lubricants doesn't give the friction or doesn't give the lower abdominal pain, doesn't give the discomfort, you may try. So few tried and we got a very positive feedback and they were feeling completely happy with that. As clients gained confidence in our approach, they became FPI's clinic ambassadors. Few challenges they faced for accessing services where they could not explain the problems openly, couldn't come to the hospital alone, lack of money to seek treatment, scared of to visit the hospital at first. Children had no time to attend respondents' needs due to their working schedule. Women in the study group belong to different backgrounds, education levels, different economic class, etc. Still, there were challenges to the accessibility of the services. 1/5 of the women experienced gynec problems, 20% due to stress that manifested into physical changes, and 40% of the menopausal women suffer due to hormonal imbalance, hot flushes, mood swings, etc., and are neglected by the husbands and family members, leading to lonely feelings and stress. My recommendations are: it is recommended to develop targeted educational programs and awareness campaigns to increase understanding of SRH issues specific to aging populations, including menopause and elderly, including regular screening and preventive measures, hormonal and non-hormonal treatment options. Thank you.
Thank you very, very much. Another really important presentation. Without further ado, we'll go to a duo presentation now. So I'm very excited to welcome Vinitha and Ragini. Vinitha is is it Baoyan? Is that correct? Baoyan, queer feminist researcher with a specialization in sexual and reproductive health and rights. Her work with feminist movement spaces emphasizes abortion rights, particularly through the lenses of a queer and anti-caste narrative. And Ragini is an independent consultant specializing in sexual and reproductive health and rights with a focus on access to contraception and safe abortion. She creates knowledge products and engages in strategic communication for normative change alongside conductive qualitative and digital research. And both Ragini and Vinitha are going to be talking from the experience of India, and specifically on the, I'm just going back to my notes, on the trends and tactics of anti-choice in India, an analysis through media and community monitoring.
Thank you. Good afternoon, everyone. So the topic, as mentioned, is unveiling the anti-choice agenda in India, mapping opposition groups, narratives, and tactics, and implications for marginalized communities. And like to give a context, like India has law on abortion, and it from like 1971. Accord was also like, there were high maternal mortality rates in India because of unsafe abortion, and doctors were getting persecuted under the law, and which is why, like, it's not abortion seeker centric law, but actually a provider centric law, like specifically from a lens of population control. And like abortion still is highly restrictive because of a lot of, like, social stigma. And it doesn't cover a lot of, like, abortion seekers from and its diversity. So but like, like opposition in India, like was not very prevalent. So what we did was, like, Common Health, what we did was try to understand, monitor, like, who are these key actors, and like what are the tactics and messaging that they are also propagating, like apart from explicit opposition, like, who are explicitly talking about like anti-abortion. So so we try to map it in media, policy, society, and healthcare levels, and we try to look at it from keyword searching in 3 languages, in social media and websites, And we particularly chose like southern and northern regions of India because we saw like a lot of activities in these regions, and also in the context, like, these two regions are also often excluded from the mainstream discourse. The other reason that we also tried to do was, like, like to see like whatever is in the social media, like how it also is panning out on ground at the grassroots level. So we tried to validate those like information, whatever we found on media.
For the results, we tried to profile the key entities that are involved in generating this discourse and partaking in these activities. And out of those key entities, these are 8 entities, by the way, 4 were NGOs and 4 were religious institutions. And they exhibited diverse religious profiles. And they have different target groups, mostly, very alarmingly, children and women. By studying the discourse that they're generating and have been generating over the years, we have sort of profiled the key narratives and emerging themes. Opposition towards abortion is embedded in a larger anti-gender, anti-SRHR environment. And alarmingly, they're using disinformation to persuade people, and especially young people. The dominant narrative that it's emerging is that the life from conception argument, that life begins from conception, and hence this fetus is a human and is thus entitled to moral and legal entitlements. It has to, it will come under the purview of the law to kill this human being, and is thus against the right to life and right to equality. There is, of course, scientific manipulation. If you visit any of their websites, there will be like APA 7 formatting references of research papers and references that we tried to actually find in different repositories, but alas, unfortunately, there aren't. But very alarming evidence that they have cited, saying that abortion causes ovarian cancer and breast cancer and will cause a lot of psychological distress. And this is by far the most alarming and most distressing finding, is that through educational outreach and massive educational outreach, which consists of seminars, workshops, and it's even happening like every month. So these are some of the imagery that they have used. These are highly sensationalist images. And these are some of the strategic tactics and public outreach activities that they're employing. Mostly it's crisis helplines. They have set up crisis helplines for people going through under unplanned pregnancies, and they provide, or they claim to provide, accurate information, and also set up linkages with crisis pregnancy centers that provide these people going through unplanned pregnancies with livelihood, with shelter, with medical help. But also they exclusively provide or say that adoption or parenthood is the only viable alternative to unplanned pregnancy. Of course, I have already mentioned about educational outreach through massive workshops and seminars, social media campaigns. 10th August, which is the anniversary of the Medical Termination of Pregnancy Act 1972. Regularly on 10th August, you will see these entities posting things like Black Day or abortion is murder. And of course, mass mobilization that Vinita has already touched upon, where more than 2,000 people, including gynecologists, doctors, come out on the streets. We want to repeal the MTP Act because it is unconstitutional, since it advocates for the murder of the unborn child. So in conclusion, it definitely undermines safe and legal abortion services. It results in increased unsafe abortions. It reinforces the stigma and shame that is already existing. They're using faith-based organizations, and it's so strong. The thing is that when they say something, it is with such urgency, with such immediacy. What we are saying, seems like there's still time, but what they are saying seems more personal, emotional, and has more power to sway. And the uses of pseudoscientific claims, then in an environment where there is already lack of information and awareness, There are moral and legal tactics where religious texts from the Bible and from the Hindu texts are used to reinforce their arguments. And of course, this has far-reaching implication for trans people and marginalized folks who already have so much barriers to access. And with this added information on the unnaturalness and how this is perpetuating a culture that is very unlike to India's, is just marginalizing them further. For recommendations, we recommend that we develop counter strategies, very proactive, context-specific counter strategies that address this stigma and misinformation. And we focus this on protecting reproductive autonomy. There is a need for more cross-border collaboration. We need to sit together, SRHR advocates working across the world, and civil society members. We need to sit together and think about how to counteract this, since it is clearly a transnational movement. Our study was a more preliminary study. There needs to be constant monitoring to deconstruct what this global trend, what is their agenda, and how they are, since this is very clearly well-funded and they're so strong in how they operate. Yes, just that. Thank you so much.
And then we'll go to our next and last panelist. So I'm very pleased to welcome Hasala Vimalaratne to the podium. A 26-year-old final year student at the Zhejiang University in China. He has a strong passion for reproductive health, and in particular is interested in the latest trends and advancement in the field of sexual reproductive health. And he will be presenting on the adaptability of China's post-one-child policy sub-fertility strategies to Sri Lanka's reproductive health care framework. So really looking forward to hearing more about that. So go ahead.
Thank you for the introduction, and good afternoon, everyone. Thank you for being here today. So the topic of my own research is assessing the adaptability of China's post-one-child policy sub-fertility strategies to Sri Lanka's own reproductive healthcare framework. So here, what I'm trying to explore is how Sri Lanka could adopt from China's one-child policy after its relaxation, and how it can be used to overcome the sub-fertility challenges that we are facing currently in Sri Lanka, and how to embody that to a Sri Lankan own framework. So let me start with the methodology here. So I approached this complex question with a comprehensive literature review. So here I have selected more than 100 studies, and they were systematically categorized by themes, including the sub-fertility trends and demographic shifts, the assisted reproductive technology clinical outcomes, the government policies on fertility treatments, and the socioeconomic barriers faced. And I would say that other than these literature reviews, I came out to these conclusions, and the data I used were also on my experience that I faced in China. So let's jump on the results. So first, here I give some recommendations and results. So first, we need to improve our public health services. And then we can use data-driven systems and advanced technological methodologies. Like in China, they currently have a decision support system, which is used in vitro fertilization mainly. Other than that, there are robust data management systems like the China's ART system, or like the Assisted Reproductive Technology Information System, which is crucial for their own policy making and their practical improvements. Other than that, they have incorporated advanced technology in sperm assessment technologies, which also enhances the accuracy and the consistency of the data sets. Then in China, they have this thing called phase development models. So in phase development models, they introduce strategies gradually. This step-by-step approach would encourage smooth adaptation and greater public support. Then medical legal policy changes are also crucial. They have developed guidelines for posthumous assisted reproduction, which is the use of cryopreserved sperms, eggs, or embryos after the donor's death. I see this area is often neglected in Sri Lanka due to the lack of policies and the guidelines. Next, it's essential to address the social and cultural norms surrounding male infertility, especially. This can lead to underdiagnosis and inadequate care. So, addressing this male infertility is through targeted interventions could also improve the reproductive outcomes. Then we have leveraging family planning, education, and awareness. So in China, they have these mobile health platforms that have family planning, education, and awareness programs within those many programs. And they also have influencer partnerships. Then there are training healthcare providers on the latest assisted reproductive technology techniques and encouraging research and development. So before I conclude, I'll like to go through the recommendations that were based on these strategies that China equipped. Firstly, we need comprehensive national policies. Another step is in implementing the advanced data systems that I previously mentioned. I also propose creating national and private insurances. Also integrating the reproductive healthcare for infertile individuals into the national public systems. Here, as I previously mentioned, the posthumous assisted reproduction. Then we can enhance our healthcare infrastructure, especially by establishing fertility centers in suburban areas and rural areas. Then we can have collaborations with Chinese universities and healthcare providers, and this can help strengthen our own healthcare framework. Lastly, culturally sensitive programs and community engagement initiatives which can particularly address the male infertility issue. And it's essential, I think it's essential for educating the public and fostering a supportive environment in Sri Lanka. So in conclusion, China's journey from the one-child policy to actively supporting fertility treatments hold valuable lessons. This proposal offers a vision for Sri Lanka, a valuable framework that addresses medical and legal gaps while building a community-centered support system. By adopting these insights, we can build a more accessible and a culturally sensitive subfertility treatment framework in Sri Lanka. Here I've given all the references that I've used. With that, I will conclude my presentation. Thank you for your attention and for the commitment to advancing reproductive health care in Sri Lanka.